So first of all, welcome all of you to be joining in this Interventional Insight. I truly welcome all of you. And to start with, let's first introduce Integris MedTech, which is the major holding company. At the moment, we have two arms. First one is Everlife, by the name of Everlife, which is into analytical equipment platform across South and Southeast Asia. Then comes Translumina, which is into interventional cardiology, along with Lamit and Blue Medical. And the purpose of keeping this box as empty for future partnerships and alliances. Coming into our diverse portfolio, we are into cardiovascular, having stents, balloons, IVL, vascular therapy, and other products. Talking about in vitro, which is Everlife, we have immunodiagnostics, clinical chemistry, hematology, molecular diagnostics, and others, along with scientific lab solutions. Talking about our market positioning, we are ranked number 1 for scientific lab solutions for Everlife. And as per NIC data, we are ranked number 2 as the largest stent player in India. And number 1, if we talk about domestic stent players. As of the moment, we have 18% market share in coronary stents in India, and we have unparalleled market access with 2,000 plus hospitals and 17,000 plus laboratories, which are directly being covered by us. As of the moment, we are partnered with 350 plus distributors along 60 plus countries. We are backed with strong R&D and manufacturing, having 100 plus SKU manufacturing units with 7 manufacturing centers in India and Europe, along with 2 R&D centers. Yeah, talking about our portfolio, we are into cardiovascular, as we already discussed, including polymer free stents, which we are going to discuss in depth today, with advanced DCBs, calcium modification technologies, vascular accessories. Talking about our in vitro diagnostic Everlife wing, we are into immunodiagnostics, hematology, and others. Along with that, we are strategically partnered with Shockwave, Sys Medical, Assist, Kanika, and Asahi. Deep diving into Translumina, we have a presence in 50 plus countries with 5 manufacturing facilities with 3 acquisitions, as we already discussed in the last slides. Along with our comprehensive product portfolio, we are available from access till the treatment. For access, we have Asahi, which is Asahi guide wires. Then we have Kanika, we have vascular accessories. Talking about assessing the lesion, we are available with Opsins, Assist. And to prepare, we have Shockwave Medical. We have partnered with Shockwave Medical. We have Optima NC balloons. We have Sys Medical balloons. Then for the treatment, we have Yukon Choice stents, Vivo SR, drug-eluting balloons, and Medinol. Along with, we also have a very unique offering called Vivo SR's Assurance Card. We are so sure about the quality of polymer-free Vivo SR that we provide a lifetime warranty card, which ensures a lifetime free replacement of the stent within the same lesion. So with Vivo SR, the patient is basically assured for life. Which brings us, circles back to today's Interventional Insight. Thank you all for joining. We have our speaker, Dr. Hugh, and this session will be moderated by Dr. Hitesh. So Dr. Hitesh, the floor is yours.
Thank you for the kind introduction of the company as whole. As you rightly told, it is whole armamentarium right from access to the device into the long-term outcome with protecting the patients for recurrent event as well. So herewith I will start the platform. We have what very esteemed, renowned Dr. Hugh Bertrand, who is head of the Department of Cardiology from Vietnam National Heart Institute and Manchme Hospital, Hanoi, Vietnam. He is going to be with us throughout the session. Along with him, I will be moderating the session. We have our renowned speaker with us, Dr. Jasraj Panwar. He is a consultant interventional cardiologist from SMBS Swaminarayan Hospital, Gandhinagar. Dr. G. Arun Kumar is an interventional cardiologist from Peters Medical College, Hosur. Then we have Dr. Vivek Mahajan, interventional cardiologist, Fortis Hospital, Kalyan. We have with us Dr. Bala Vignesh. He is an interventional cardiologist from Naravi Hospital, Vellore. So these are the speakers who are going to present some of the complex cases, and we will have a discussion afterwards. Then we have the expert panelist with us, Dr. Gaurang Patel. He is from the Shanku Hospital, Mehsana, Gujarat. Dr. Kaushik Mana, consultant interventional cardiologist from Narayana Hrudayalaya Hospital. Then we have with us Dr. Ashwin Kumar Panda. He is a consultant interventional cardiologist, Medicover Hospital, Vizag. So these are the forum we have on our board, and the flow of the discussion will be like the way I've introduced the program. Then there will be first complex case presentation by Dr. Tran, followed by the presentation by Dr. Jasraj, then Dr. Arun Kumar, then Dr. Vivek, and then Dr. Bala. And afterwards, we will have a one-to-one discussion for all the cases, all faculties, and the expert panelist. So with that, I will hand over the floor to Dr. Tran to carry forward the further presentation. Thank you.
Yeah, so first of all, we would like to thank the Chance Lumina to host this webinar. Is very interesting, and so we have this maybe a chance may have a chance to cooperate as well as maybe have conversations with the Indian doctor, and secondly. And secondly, today's I would like to give my talk. My presentations with the title Polymer Free DES in CTO intervention and case perspective. In clinical practice, CTO intervention is also my hobbies in daily practice. And so I do not have maybe any potential conflict of interest, and so here's maybe this historic pictures because it's over the 50 years, over 5 decades. We have is since from the first PTCI in 1977, and so it is witnessed as maybe this extraordinary progress of the PCI in the over the world. And so now, since now, as you can maybe familiar, it's very easy and quite maybe familiar to deal of maybe this simple case of PCI. But now, till now, the CTO is also the highest levels of interventions. And so in CTO, you have maybe to deal with the calcification, proximal gap, ambiguity, tortuosity, or maybe even the left main or bifurcation in one ME. And so till now, we also have maybe this concept of cheap CTO because besides the lesion complexity is also related to the patient risk. And also in the setting of CTO, you have to deal with multivascular disease or patient with have impaired LV function or heart failure or severe ischemic coronary disease, or even that's called dominant severe valvular heart disease. And also, when you recognize this CTO interventions, you also have to deal with this field disease. It is hard to treat, and so we need to long-standing, and it's very important. We need to have a bit of long-term data in any stand in case as we put a stand in. And so 10 years ago, when we talk when we talk about CTO, it's real. Why it just think that's about for Japanese operator, but now in over the world, the success rate of the CTO PCI have become uniform. You can see maybe the same rate of technical success, even antegrade or maybe retrograde approach, even in US, Europe, or Asian Pacific. And so that's in reference center, the rate of the CTOs, the number of PCO is maybe reach to maybe 20 or 30% of the over PCI volume in any center. And because that's as shown in previous slide, you can say when recognize the CTO, also that we have maybe the long diffuse and also combined with maybe this low LVEF or even in the subsets of chip. and also you can see is even when you put the stent, when you see this, you need maybe the long-term data outcome. And in the 19 RCT involving more than 25,000 patients, you can see that maybe the stent related event continue to occur at the rate of around maybe 2% per year between 1 and 5 years after PCI. And this rate has not meaningfully improved as the technologies has evolved from BMS to contemporary DES. And also we need maybe the revolutions of the DES over the time. And also any revolution is around maybe the polymers, the drugs, as well as maybe the bare metal and the catch of the stent. And now it's widely spread as a serial of the DS delay arterial healing. And so that's and one of the because that's maybe it is really that's maybe inflammatory response to durable polymer coating. And so that's in the time and so in history they are maybe to develop the polymer free generation of ES, or maybe develop the biodegradable polymer coated DS. And so that is a demand to have a newer DS. And so we also say and also we need maybe the long-term outcome for the patients, for the any stand to when you intend to put for the patient. And now in Vietnam we also have the Vivo ISA, because we have maybe the first the world's first regarded as the world's first dual drug polymer free DES. And so now, and as we see this maybe divide into ultra-thin or intermediate thick, is maybe is classified as maybe the thin strut. And so it also is maintained its radiant strength. And it's very important that you need maybe the long-term outcome. And so it's the 2-year data or 5-year data, it establishes the safety and efficacy in complex patients, even in diabetes or the STEMI follow-up to maybe the 5-year. And you can see this at maybe the 5 years, the Vivo eyes, as we know, polymer demonstrate similar rate, definite or probable stent thrombosis as compared permanent polymers, zoterolimers. And its data is reported in JACC, or is very famous research or famous paper. And so that we have maybe a strong confident to put the stent in the patient. In another view, that's in Vivo is very important when you recognize the CTO. Is very includes classifications, or maybe the loudest view, or maybe it's tortuosity. And so we need maybe the well-performed deliverability, and the crossing profile is good. And so now in the picture, you can see this compared to the Science Expedition or Synergy or Zero, you can see that maybe the visualizer enhanced deliverability with the lowest crossing profiles for the patient. One more important point is that we need to have a bit long-term outcome for the patient. And so here's a slide. We can see that maybe there's a research in more than 3,000 patients who enrolled and randomized, and we can see that a 10 years clinical outcome from RCT compares Vivo eyes as compared to the permanent polymers zoterolimers in coronary disease. And so in 10 years long-term analysis, the Vivo eyes shows the similar efficacy and safety profiles compared to the resolute integrity. And you can see that the maze of the post and the post and the dose and the post is quite comparable with 2 arms. And so now when we analyze more analysis to this diabetes, we also have maybe the long-term data. When you compare this, maybe the 2 arms, you can see that about the mass is comparable between the 2 arms, the Vivo ISA and the Resolute in patient with that in diabetes. And so when we focus on the target vessels related to MIs, you can it's notably low rate of target vessels related myocardial infarctions in this in the vivo ISAs is maybe less than 33% compared to the Resolute. And so here also have maybe several examples for the case we use vivo ISA for the patients. Here the first case is a female 71 patients, and we do the CTO for the patients. And here's when we see the caudal view or the cranial view is my stenosis, restenosis already when we see that. And when we check it in the view to analyze this the restenosis of the in the stent LAD. And here's for when we check maybe to the RCA, you can see that's maybe anomalous origins of RCA, and the CTOs from the mid RCA to the distant RCA, and the collators from the distant collators from the septum from LD. And so in this case, we do the DB for the patient in LD stent. Then we do the patients for then we use the Sion Black and Gaia 1, so Gaia first and Gaia second to maybe to retrograde approach to maybe to RCA and then now. And here in this case, we use snare to because there's an anomalous origin of RCAs, we use a snare to catch the RZ3. Then in this case, we put a 3 vivo ISA stand for the patient, and so the final result is good. And so in this case, we can see this maybe the reason why we put the stand here, because that's maybe the cost is reasonable, as well as maybe the long-term data outcome we can also have for the patients. The age is around maybe 70 years old. And so the second case is for the also for the CTO intervention. You can see that's maybe the calcification as maybe the collators, cell collators for the in the LAD. And and so here in the 4-chamber view as well, here we can see that's maybe the CTO in the spider view. In this space, and here's for when we see that's maybe the collators is not maybe the cell collators in the LAD. So in this case is quite interesting, is that because the first term we cannot cross undilatables or uncrossables this microcatheters, or maybe this cannot engage microcatheter direct pre-dilatations over the guy is not also okay. And so we have to stop this case. We have to stop this case at the first attempt. And so the second attempt, maybe it's 2 months ago, we decide to maybe another strategies for this case. Because that's in this case, we as you see, that's maybe this when we do that, we think that's because of the calcification. So the stuck at the point of calcification, and so intra-plug wiring. And so we try to subinterspace at the proximal LADs, and so later to train this calcifications for this case. And so 1 month later, we can do also the femoral access, and we use the Corsair Gaia 2 and 3 suboptimal. And so then later we cannot so that's later we use Conquest 8-20 to avoid the old way and beyond the band to change the Gaia 1 and second to the true lumen. And so that we deliver easily for the microcatheter, as well as maybe this for the small balloons for this case. And we can maybe to recognize the CTO is okay. And so in this case, we also try to put maybe the 4 stent with the vivo ISAs at different size of the stent. And so here we can see that's maybe when we check the slide, maybe the TME flow is good, and also check as the 4-chamber view is also. Also in another case, when we see that's with the cost reasonable, and so we need the long-term data outcome for the patient. We also can do for another retrograde CTO, or maybe even that's maybe very torturous when we retrograde approach. And so from this example, we can have maybe the take-home message for this in this presentation. And it is witnessed as a CTO PCI is become more popular with time, and success rates become uniform. And so but in the clinical practice, I think it's demand for the newer DS to solve as a mess in the various setting and in various in different country and different with a reasonable benefit and the cost. And so to maybe to have maybe to reduce the mess, as well as maybe to have maybe this a small better and better the result of the patients with time. We need to share mutual learning good ways to break it better, and we also need to improve the outcome for the patient. And thank you for your attention. Yeah, thank you.
Thank you, Dr. Tran, for excellent presentation and some of like heroic case which you managed, and with very, very technically and cosmetically good result. So we will keep the discussion at the end.
Hi, this is Dr. Ashwin from Visakhapatnam. Can you hear me?
Yeah, we can hear you, doctor. I think Dr.
Just in case if there is a delay on something, we could rather share some, if anyone is interested.
I think Dr. Vivek has joined.
So okay, we'll go ahead. We'll go ahead.
Thank you, Dr. Ashwin, for taking up. Hi, Dr. Vivek.
Hi. Should I share my slides?
Yes, you may.
I'm Dr. Vivek Mahajan, and today I shall be talking about this Vivo ISR stent and my experiences with some of the cases. So let's begin with this study. This is a GLP study design. Here it was done in Munich, in Germany, at the IMTR, the Institute of Minimal Technology and Research. Here they use the pig as the study animal, and they studied the stent, which is the Vivo ISR, and compared it with the other two stents. We'll go to the study design objective. The aim of this study was to investigate early and intermediate performance and safety of translumina stent, ISR Summit, which is a cobalt chromium stent with everolimus, and Vivo ISR, which is cobalt chromium stent with sirolimus. Both of these are polymer free probucol containing stent. The probucol serves as a polymer and it dissolves after 28 days. And this was compared with two controls. One was the translumina Yukon choice, which is a stainless steel stent with sirolimus, and it is a polymer containing stent. And another control stent, which is the translumina SS. They have not mentioned the name, but it is against the stainless steel stent with probucol. So before we go on to the study design, let us compare the four stents here. So the four stent designs are shown at the lower bottom of this slide. You can see the ISR Summit and the Vivo ISR are similar platforms. They are both cobalt chromium stents. Both are polymer free stents. The only difference between them is the ISR Summit has everolimus and the Vivo ISR has sirolimus as the drug. And the two controls are, one is the Yukon choice PC and the other is the unknown control drug eluting stent from translumina itself. Both are stainless steel containing stents. The Yukon choice is a polymer containing stent, and the control DES, the unknown stent, is a probucol containing stent. Both are sirolimus eluting stents. So here is the study design. They had 32 conventional pigs, farm pigs, and they implanted around 40 stents in them. And they studied at the animals at 3 stages. In the first stage, the electron microscopy was done 14 days after stent implantation. 3 each of the ISR Summit, the control stent, unknown stent, and the Vivo ISR were studied at 14 days with the electron microscopy. Then the next batch of the study was at 28 days. Here the QC and histopathological analysis was done with 10 stents each of ISAR Summit, Yukon Choice PC and Control DES and the Vivo ISAR. And the next batch of the study was at 90 days. Again here QCA was done and histopathological analysis was done again with 10 stents each of the ISAR Summit, Yukon Choice PC, Control DES and Vivo ISAR. They wanted to find out if there is any difference between sirolimus and everolimus, whether there is a difference between Vivo ISAR and ISAR Summit, because the only difference between Vivo ISAR and ISAR Summit is the drug, everolimus versus sirolimus. Otherwise, the stent platform is the same, Probucol is the same. Then they wanted to find out whether there is a difference between the two backbones, the stainless steel backbone and the cobalt chromium backbone. So Vivo ISAR has the cobalt chromium background, Vivo ISAR Summit has the cobalt chromium background, and the other two stents, that is the Yukon and the Control DES, had a stainless steel platform. And the third thing they wanted to compare is the polymer versus the Probucol, which shows lesser inflammation. So here Yukon Choice PC was the only polymer containing stent, whereas Vivo ISAR, ISAR Summit and the Control DES were all polymer free stents. And the parameters were to assess the re-endothelialization process and vascular healing response. They wanted to check the percentage of uncovered struts because that is an important predictor of late stent thrombosis. They wanted to assess the safety, fibrin deposition, inflammation, and endothelialization, and they wanted to appreciate the efficacy, that is the percentage stenosis. So these are just representative images to just give an idea of how the histopathological analysis was done. Let's jump to the summary of the results. Summary-wise, the cobalt chromium platform was better than the stainless steel platform, but there was no difference between the sirolimus and everolimus containing stents. When it came to polymer versus polymer free, then there was a reduced inflammation in the Vivo ISAR and ISAR Summit as compared to the Yukon Choice. Vivo ISAR and ISAR Summit showed accelerated vascular healing compared to the polymer coated drug eluting stent. Probucol seems to be much safer alternative to polymers for drug release, resulting in the better anti-restenotic efficacy for Vivo ISAR and ISAR Summit. And the two devices, the Probucol containing devices, showed favorable outcome with minimal to low neointimal growth at 28 and 90 days respectively, and absence of significant fibrin deposition at 90 days and no excessive inflammation. So this is a wonderful study which says that the stent platform does matter. Your cobalt chromium stents do better than the stainless steel platforms. The drug does not matter, sirolimus or everolimus, but having a polymer or not having a polymer, the Probucol does better than the polymer containing stents. So some of my experiences with the Vivo ISAR over the last 5-7 years. So this is a patient. I don't think you can appreciate that there is a stent from the proximal LAD to the mid LAD, and there is a ISR in the stent. The 90% stenosis, and the mid part appears to be okay. The mid LAD part of the stent appears to be okay, and there is a big diagonal coming out of it. So this patient came up with a new onset of exertional angina, and we admitted him for angio. There was a 90% instant re-stenosis. I'm not sure whether you can appreciate the stent here, but there is a stent and there is a ISR here. So we took him for the intervention. We pre-dilated with 2 and 2.5 millimeters balloon. Then we took a cutting balloon, and with the cutting balloon, we dilated across the diagonal and in the proximal LAD. Then we deployed a 3.5 by 24 stents, and we can see the result on the left-hand side. After that, post-dilatation was done. This is the post-dilatation with the 3.5 NC traveler at 18 atmospheres. And post-dilatation, this is the result. Here the diagonal is now jailed. The old stent is there, and we have put the new stent across the diagonal. So across the diagonal mouth, there are two stents, and initially there was some ISR just proximal to the diagonal origin. But now we can see excellent result with this Vivo ISAR stent in a in a case of instant restenosis, we got an area of around 7 millimeters, square millimeters in the proximal LAD, which is quite good. And then you can see some borderline lesion in the OM. We also tackled that. The OM was just 2.25 millimeters in diameter. I could have left it alone, but the patient was insistent that he wanted to do it. So we said that we are not going to put a 2 millimeter stent because the area which we get after 2 millimeter stent is very less. So I put a 2.5 millimeter stent. So this was slightly oversized for this artery, but in spite of being oversized, the artery took the stent very well. We ended up a little bit overinflating the artery. And this is the final result. So in a 2.2 artery, we could put a 2.5 stent, overinflated it, but there was no edge dissection. So that is the beauty of this stent. You very rarely get any edge dissection, even if you slightly oversize the stent. So now this is another patient who had come with a new onset of exertional angina. She has a proximal LAD lesion, and there is a lesion in the distal LAD as well. The between part, the mid LAD appears to be okay, but we did a OCT for this patient, and the OCT showed that even the mid LAD contained a high lipid burden, and it was not very healthy, and at places there were the area was quite borderline. So we decided to stent the entire artery, but the length of the entire artery came out to be around length of the stent came out to be 64 millimeters. So I was quite skeptical to put such a long stent, but this is how it went. We did a cutting balloon dilatation of the distal lesion with 2.75 Wolverine, and with the same balloon we pre-dilated the proximal lesions as well. Then we put a long stent 3 by 48 in the mid to the distal LAD, and in the proximal LAD we put a shorter stent 3.5 by 24. Post-dilated the distal part with 3 and the proximal part with 3.5. And this is the result which we got. So this was slightly fibrotic lesion, some calcium as well, a very long lesion, 64 millimeters. Many times there is a fear in the minds of the cardiologists that such a long stent would develop ISR, but now the patient is doing very well since 3 years. She has no exertional angina, she is good activity, and I think the stent is working quite well. And you can see these branches as well, 2 or 3 diagonals are coming out. They are all well preserved. So the side branch protection with the stent is excellent. This is another case that I want to show. Here there are 2 lesions, one in the LAD. The LAD lesion is calcified, and the circumflex lesion has a the circumflex to OM lesion has a distal circumflex as a side brancher. So the right hand side image is the post stenting. We could get a good expansion of the stent in the calcified lesion. We got an area of around 7.5, and in the LCX also we got a very good area. And see the side branch again, it is very well preserved. The OM distally was only 2.75 to 3 millimeters, but we could post dilate it up to 3.5 without causing any edge dissection. That is the beauty of the stent, that even if you slightly oversize the stent, you do not cause any edge dissections. This is another case. We are in the secure. We are a part of the secure registry. In the secure registry, we are trying to stop the double antiplatelet agents, the ecosprin and ticagrelor, or ecosprin and clopidogrel, after 3 months, and we are just giving the single antiplatelet agent after 3 months in patients who have undergone a stenting with the Vivo ISAR stent. And this TPN patient was included in the secure registry. Here again, the patient has undergone angioplasty to 2 arteries. You cannot appreciate the LAD lesion in this view, but trust me, there is a LAD lesion which is eccentric in the mid LAD from. So we had to fix that, and there is a OM lesion here which we can very well appreciate. So after the angioplasty, this is the result. We put a stent from the septal artery to the mid LAD, and in the OM as well we put a 3.5 stent. And this patient came up after 6 months. So this is the initial angioplasty done on 3/4/2025. You can see the result here. In the LED, there is a stent in the mid LED, and in the OM, there is a stent in the proximal OM, distal L6 to proximal OM. And the result, after 6 months, the patient came back with some chest pain. He was quite anxious that he had a stent thrombosis or something like that. We tried to convince him that it is nothing, but he insisted on an angio, and this is the result after 6 months. The stents are very well patent. There is no ISR at all, and just proves that the stent is very well durable as well. And many a times we believe that there are some specialized stents for the left main, but I'm quite comfortable using this stent in the left main PCI as well. So there is a patient who was 160 kilograms in weight. She had a primary angioplasty around 5 years back, and she did not take any medications. Her sugar never came down below 250, and she developed a ISR just at the edge, in segment restenosis, just at the proximal edge of the stent. And we decided to do a left main to LED stenting. Here again, we use a cutting balloon, and this is the result on the right-hand side. We got a great result with the, we put a 3.5 stent. The distal dilatation was done with 3.5, and port was done with a 4O balloon. You can appreciate the circumflex. Circumflex is well preserved. The side branch protection is excellent. And we got a great result. Again, this patient is doing well since the last 2 years. And the last case that I would like to show you is this gentleman who had come with a anterior wall MI. It was a primary angioplasty. The LED was occluded from the mid. You can appreciate that. And then we did a thrombus aspiration, then dilatation, and we had to do a cutting balloon with a 2.5 because there was some calcium visible. And in the end, we put a 2.75 stent, and the stent was quite oversized. But fortunately, the stent is so good that it does not dissect. Even if you put in a smaller artery, you can get away with it. And the side branch protection, again, you can note the diagonal is well preserved here. There is no stenosis as well at all. So there are some properties of the stent that I would like to appreciate, that it protects the side branch well. I do not see much of edge dissections. I have safely used very long stents in very tortuous arteries. The trackability is very good, and it's almost 5 to 7 years that we have been using this stent. And we are also a part of the secure registry. We have recruited around 110 patients in the last 1 year. And fortunately, even after stopping the aspirin after 3 months and continuing on the single antiplatelet therapy, we have not experienced any adverse cardiac events, no stent thrombosis, no ISR. Only one patient had this check angio that I showed you, this TPN patient, and it was also patent. So with that, I conclude this talk. Any questions? We can have a discussion.
Excellent, Dr. Vivek, the presentations. May I request, we will keep the question answer session at the end. I may request Dr. Bala if he is ready for presentation, or Dr. Arun Kumar, whomsoever is ready. And
so good evening, everyone. So as the topic is about stents, the polymer free advantage in STEMI. So how does it work in STEMI patients, whether polymer free stents have any advantage or not? Mechanistic and clinical advantage illustrated through an IVL optimized primary PCI. STEMI lesion pathobiology. As we know, the ACS block characteristics, lipid core, inflammation, thrombus. ACS blocks in STEMI feature a large lipid core with intense inflammation and superimposed thrombus, driving rapid lesion instability and occlusion, necessitating a prompt revascularization strategy. And polymer DES does increase the risk of further inflammation and delay endothelial healing to some extent, and promotes neoatherosclerosis in comparison to a polymer-free DES, compromising on the long-term vessel patency and elevating stent thrombosis risk. So polymer-free DES minimizes the chronic inflammation by eliminating polymer-induced hypersensitivity, reducing neointimal hyperplasia and late thrombosis, and thereby enhances the vascular healing in STEMI patients post-PCI. So calcified culprit physiology and challenges. And we know that in STEMI patients with a calcified lesion, it's very tough to deal, mainly in terms of underexpansion malapposition. So severe calcification increases the risk of lesion underexpansion malapposition, compromising stent apposition, drug delivery, and long-term vessel healing. Polymer DES limitations in STEMI. The inflamed STEMI lesions exhibit heightened inflammatory responses, increasing the thrombosis risk, delayed healing and restenosis. IVL plus polymer free DES as a therapeutic solution. When there is heavy calcium in primary PCA patients, IVL serves as an important measure where aorta cannot be used, and in those cases, definitely IVL serves to open the calcium, and polymer free DES also prevents the risk of heavy thrombosis. Solution preparation using IVL, acoustic microfracture mechanism on calcified lesions. It creates controlled cracks in calcified plaques, enhancing the vessel compliance and facilitating optimal stent expansion. Endothelial preservation is there in compared to rota, minimizing the vascular injury mainly in STEMI patients undergoing primary PCI. So no reflow phenomenon is less. Imaging guided optimized stent expansion. Intravascular imaging guides the IVL enhanced lesion preparation, enabling precise plaque modification and uniform stent expansion, reducing malapposition and improving the acute procedural outcomes in STEMI. Synergy between IVL and polymer free DES. IVL effectively modify the calcified lesions, enhancing polymer free DES expansion and drug delivery, minimizing inflammatory responses and promoting superior endothelial healing. Polymer free DES, mechanistic rationale, absence of polymer and its impact on inflammation. Polymer free design minimizes the chronic inflammation by eliminating polymer related hypersensitivity, enhancing vascular healing and reducing the late stent thrombosis. Enhanced endothelial recovery and reduced neoatherosclerosis. Polymer free DES promotes faster endothelial recovery by minimizing inflammation and polymer related toxicity, improving the long-term vessel healing in post-STEMI intervention. Dual drug matrix, sirolimus plus propofol roles. Sirolimus inhibits the neointimal hyperplasia, while propofol enhances the drug retention and anti-inflammatory effects. Durable clinical outcomes versus polymer-based DES. Optimized lesion preparation with IVL enhances the drug uptake in polymer-free Vivo stents, reducing inflammation and late thrombosis, thereby delivering durable clinical outcomes superior to polymer DES. ISAR technology mechanism, reduced stud thickness, polymer-free propofol-based drug matrix, immediate drug transfer, and avoidance of polymer-induced chronic inflammation. So the reduced stud thickness, polymer-free lower stud thickness platforms enhance endothelialization and reduce the inflammatory response. Polymer-free propofol-based drug matrix, it has a controlled drug release, reducing the inflammatory responses and improving the endothelial healing and minimizing restenosis in STEMI patients. Immediate drug transfer and sustained retention. ISAR technology enables immediate drug transfer to the direct vessel wall contact, ensuring rapid therapeutic effect. Avoidance of polymer-induced chronic inflammation. ISAR technology eliminates the polymer use, reducing chronic inflammation and improving vascular healing post-PCI. Clinical evidence. The ISAR test trials. The ISAR test 5 study design and 1-year outcomes. ISAR test 5 compared polymer-free DES with durable polymer stents in STEMI patients, demonstrating non-inferior 1-year outcomes with reduced late complications and comparable efficacy. Long-term 5-year safety, sustained long-term safety and efficacy of polymer-free drug DES over 5 years with reduced late adverse events and comparable restenosis rates to polymer-based counterparts. 10-year follow-up data, durable vessel healing and safety. 10-year follow-up ISAR test showed sustained vessel healing, low late adverse events, and confirms the durable safety and efficacy of polymer-free DES in STEMI patients. A clinical case where acute MI, IVL, and polymer-free DES was used. So we have 81-year-old female, known case of diabetes, hypertension, and old CVA, a small hemorrhage in 2017, admitted with 1 hour of chest pain. ECG showed anterior MI, echo showed a moderate LV systolic dysfunction, mild bilateral Krebs on auscultation. Plan was primary angioplasty. So this is the baseline angiogram. The tight stenosis in the LAD with a lot of calcium, and many times in STEMI patients with a severe calcium in elderly, we notice that once you predilate with the routine non-compliant balloons, it results in a lot of slow flow and eventually VT and asystole. So the patient attendants were counseled about it, and we told them clearly that if it doesn't break with a non-compliant balloon, then other techniques should be used, and explained about the need for IVL. Cost issues were explained, and they were willing. So then wire was crossed, and then one slide is missing. And then we tried to open with the routine non-compliant balloon. It didn't break. And then we tried with the cutting balloon to see if in acute MI we can avoid IVL, but again didn't break. Then we went for the shock wave. 3 IVL balloon was used, and about 6 to 7 cycles of pulses were given. Then the vessel cracked, lesion opened. Then we deployed a VOSR DES. Size was 3x36. The tracking of the stent was easy. We didn't require any extra equipment to track. So vessel opened well, and we did the post dilatation. The NC balloon could not be tracked across the lesion, and hence we had to use a guideline to track it. But the stent, luckily the stent actually tracked well without using any other support devices. So these were the final results. So scientific takeaways: suitability of polymer free DES in STEMI with thrombus and calcium. Polymer free DES demonstrated enhanced safety and efficacy in STEMI patients with thrombus and calcification by reducing the inflammation and promoting optimal vessel healing post IVL optimized PCI. Role of IVL in lesion compliance and stent expansion: fractures the calcified plaques, facilitating optimal stent expansion and improving the long-term vessel patency. Benefits of polymer free VOSR: reduced inflammation, faster healing, and long-term patency. Thank you.
Thank you, Dr. Bala, for excellent presentation. May I request the next speaker to try to adhere to the time and just try to show the cases in more detail so that we can have some insight from experience of our international speaker, Dr. Tran. And some of the PowerPoint presentation, we try to minimize the discussion and we focus so that we can have some inputs from him.
Good evening, respected colleagues and international faculties. I'm Dr. Arun Kumar from St. Peter Medical College from Mosul, sir. So, next. I'm going to present a topic for PCI. It is a complex calcified LAD. I was stented with VOSR. Okay, so the patient history is a 51-year female. So, doctor's mother coming with chest pain and exertion is class 2 to 3 exertional angina. Is known cause of diabetes, hypertension with good LV. Straight away, I went for angiogram. So, angiogram showed LAD. Can you show LAD lesion? RCA is around 30-40 lesion, proximal LAD. L6 shows some. It's a mid LAD shows tight lesions. The D diagonal also is arising from there. D1. So next. Third slide is LAD is tight. LAD is around 80 to 90% lesion is there. And I wired through, run through to the LAD, and I track with the two. I usually take 2 balloon, but it's not tracking. So I took 1.5 into 8 balloon. It's also very difficult to track that because it's just calcium. Since I don't have IVAS, I don't have the periphery, I don't have anything. With visibility only, it was little bit severe calcium. So I went with 1.85. I'm trying to open. Little bit was open. It will give away. I got. Then I went with 2 into 12 NC. Since I'm not fully happy with the bone indentation, dog bone indentation was present. So I want to upgrade with the NC balloon. So I went to the NC. Next slide. Next slide. Is finished. Then I went the cutting balloon to 2.75 into 10 mm cutting balloon. I thoroughly cut. Then some giveaway was there. So Finally, I was happy with the opening of the balloon. So I took, and some suction flap also was there. So I want to stent immediately. So I took 275 into 23 stent. ISR, positioning and placement, everything was checked. Then I stented. Next, the polymer free Vivo ISR was stented across the mid LED lesion. Then I did post tensing. Post with 3 into 12 mm balloons. So finally, the TIMI3 flow was there. The extension expansion also very good. And the most important point, what I learned from the past 4 years, I was using this Vivo. The preparation of the bed is very important. Even for all the stent easily tracked with the preparation of the bed. But Vivo, sir, if you want to deploy in a calcified lesion, whatever the lesion, the thrombus, whatever the tortuous lesion, it can easily deploy. Only thing, the preparation of the bed is very important. If you prepare the bed, after deploying of the balloon, or after deploying of the stent, also the balloon easily it will come out. Usually, initial times I was little difficult for me. Slowly, I learned over the period by talking with the seniors, the friends, and all. So now I am okay with that. Now the initial beginners who are listening, the preparation of the blood is very important for it. All the calcified or tortuous or type A, B, whatever the lesions is there. That's what I learned. But nowadays I'm very comfortable and it's going smoothly for the period. TIMI3 flow is there. Patient is happy. I discharge the patient with very, very good signs. So take away measure.
Doctor, I
This
think
much
we
only I
lost
have
your
in
voice.
my lab. Only cutting balloon, that's all. Free drug eluting helps in better endotheliation of the elderly patients because its ulcerated acts very well. Okay, but little visibility also is good. But only thing for CTO, everything it will go very for this wonderful evening, sir. Thank you.
Doctor, we lost you in between.
I'm
Could you
audible, sir?
repeat? Now you're audible. Can you
I'm
repeat?
audible.
Yes. Can you repeat the key takeaways again? We lost your
Hello.
voice in the middle.
Hello.
Yeah, Dr. Arun. Can you repeat your key takeaway messages? We lost your voice in between.
Yeah. So first dual drug eluting polymer free drug eluting stent VOISR, which has a strong clinical beta of 10 years. So it will improve in health endothelialization of the stent. It's ideal choice for all the vessels, all the lesions. I have stented all the lesions like calcified, tortuous, CTOs, and thrombus, heavy thrombus burden. Yesterday also we did one stenting. It's hugely tracked inside the thrombus, and I stented like anything. Then the flow has come, patient got very well. So over the it works for all the calcium, all type of lesions. That's what. Then thin stress of this easily navigation through tough morphology. Also, it will go easily very well. Only thing the bed preparation of the bed is which should be very important. Some calcium is there, you should not hesitate to take some other help or like cutting balloon or whatever you have in your lab, you can use the maximum. Sometimes we don't have cutting balloon initial stage. I used to put 2 wires inside the wire and take one NC balloon. I'll keep over that NC balloon. The 2 wires will act as a cutting balloon. We did like that also so many times. Whatever the hardware you have, use it, and you can use for that betterment of the patients. Thank you, sir. Thank you.
So then we can open this forum for the discussion. Dr. Tran is still on the board. He is with us.
No, yes, he's on the call.
Okay. I think we shared some of the things with him, and let's have some input from him once we get free.
Yes. Dr. Tran, can you hear us?
Yes.
Yes. We also have our expert panelist. Dr. Ashwin is here.
Okay, so
Dr. Tran, are you able to listen me?
Dr. Ashwin is here. We as our panelist. Dr. Kaushik is here. Dr. Gaurang is here. Hi, Dr. Ashwin.
yeah.
Very good evening.
Yeah, Dr. Tran, do you able to listen me?
Yeah, I can hear you.
Yes, so there was a lot of discussion regarding polymer free stands with Vivo ISAT platform and technology. The product is in the market or inside uses for almost now more than a decade. I feel so like Vivo ISAT. But why the US FDA is not picking up because the data is also strong. Why the US companies or US people are not trying with this polymer free platform? What should be the reason? Why it is not internationally, globally more like a platform which polymer free stand should be used?
You mean that maybe it's in US it's not approved by FDA?
Yes.
Yeah, I think this maybe take a long journey, but I think that a chance Lumina is maybe important. So now in the just only the three kind of stand approved by CEC's Biofreedom, Coroflex ISA, and so create Evo. I think that's maybe in clinical practice. I use Vivo ISA is very easy to deliver, or maybe the long-term outcome, as well as maybe the several kind of stand. I think that's maybe I'm not sure about the process by FDA, and so that's I'm not sure about how to have answers for that. Yeah.
Likewise, the biodegradable stand came by the abort, but then it gone into vain after a few years of uses. That at that time the technology was promoted as one of the excellent tools, and finally it gone into the basket. So whatever the new stand platform and the third or fourth generation stands which are being used in the United States, and their design, their polymer coating, and then strut thickness, etc., and whatever the things which are used in the other counterparts, maybe even China. I don't know the status in Vietnam, but there is some difference. So, anything to comment on that?
Sorry, I don't know what you mean. Sorry.
What I meant to tell, the stand design, the platform, its strut thickness, and what the third and fourth generation DES, which is being promoted in the US market and maybe in the certain European countries, and they are not universally accepting the any not even sparing the US FDA approval, but some of the things are not because if the design and the things are such a robust data, they should take up with their own company, US company, to take this design and do the trials and get the US FDA approval, not the VSR, but their own product which have the same similar platform, and they can put it forward.
Yeah, I think that's I'm not sure about maybe the FDA process. I think that's maybe the long-term outcome, maybe the 10 years long-term outcome is just only compared to maybe the resolute integrity, and maybe it's maybe this older generations of the resolutes, and so in case that's for the long-term outcomes, maybe we have maybe to compare to maybe the newer DES generations of in US, but even in US, I think that's there is just only the I'm not sure, so that's we do not have maybe exact this as answers for that. Yeah, so I have no comment about the FDA approved for that.
Okay, thank you.
Dr. Ashwin, would you like to comment on the cases?
Hi, good evening, everyone.
Hi.
Good evening, sir. So I have used Vivo SR quite frequently in left mains actually. So I am in a tier 2 city where we have abundance of facilities, but the purchasing power is at little low. So we go for non-IVUS based cases and all. So I was happy that a lot of people are presenting those cases here. And I would like to add that the closed cell pattern, sorry, the open cell structure at the ends and all, we were very happy putting it across the branches and all, and a proper pot was fine. And I would like to add few points like for Arun sir, I guess. He said he's working in some periphery. But sir, you always don't have cutting balloons for everyone. So we are literally doing everything with poor man's cutting balloon technique, putting two wires and going ahead with your NC and breaking all the calcium. A lot of things give away, and good that you got a good result with the cutting balloon. So in case if you have any shortage of things or you have complex anatomies, you can definitely try that. Just a mere suggestion that I could like to add there. And I like Vivek Mahajan sir's cases as well. He put a bunch of them. That's good. And uh, I definitely had experience using the same stent in left mains. I was seeing if anyone wants to present in left main or so, you can happily go in and put it up because they say they can go up and down. We have used even those transluminal racer stents we are putting in credit patients at least once or twice a week. Those definitely go expand well. I don't see too much of a foreshortening, which is quite evident with any other stents when we are putting in a left main and over expanding to its limits. But this doesn't happen so with Vivo SR. And even with their latest one, Lunar Pearl is also good. And these people, because of this is polymer free coated, the struts are thin. Visibility over what you call during your cath, you struggle putting stent boost to look at the stent edges when you're going to do a pot and all. That's definitely a difficulty what we face on a day-to-day basis. They have overcome it by putting a marker at the end in the newer stent of Pearl. So I'm happy for that. But we use a G cath system. Philips ones usually put out the. We have 4 cath labs here, so Philips consoles and Philips things they make out the. You can make out the stent quite visibly, but in G you have to struggle a little bit, especially with Vivo SR and all the stents because they're thinner. Right, I'm happy that they have given me an opportunity, and I'm happy that a lot of cases have been shared, sir. Thank you.
Very glad to have you here, Dr. Ashwin. Dr. Tran, what do you think about the cases? Anything that you would like to, enlighten us with your learnings, your key takeaways?
Sorry, about which case you mean?
Any case, and not anything in particular, but anything in general about Vivo SR or about polymer free technology.
Okay, so